I'd like to welcome everybody here today to the Adelaide Biomed City Research Mini-Review. We would like to acknowledge this land that we meet on today as the traditional lands for the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Greater Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. It's my great pleasure to invite two colleagues and friends today, international leading experts in the area of atrial fibrillation, to speak about this topic today. Professor Prash Sanders is a colleague and friend. He's a clinical academic based at the University of Adelaide, the Royal Adelaide Hospital, and the South Australian Health and Medical Research Institute. He's the Director of Centre for Heart Rhythm Disorders at the University of Adelaide and Director of the Cardiac EP Service at the Royal Adelaide Hospital. He has over 600 peer-review manuscripts, predominantly in the topic that he will present today, and most recently has been awarded the Eric Sussman Prize from the College of Physicians for the best contribution of knowledge in any branch of internal medicine, the fourth only South Australian to have been awarded this prize over the last 50 years. So, Prash, thank you for talking about the developing the fourth pillar of atrial fibrillation management.
Thanks, Matt. So I'm going to talk about the fourth pillar in AF management. And before I do so, I'm just going to introduce the members of the group so that the audience has an idea of what the Centre of Heart Rhythm Disorders looks like. Although there's much cross-pollination and collaboration within this group, I lead the group that manages the atrial arrhythmia space. Glenn Young's been focused on the implantable devices, Kurt Roberts-Thompson on ventricular arrhythmias. Dennis Lau has taken on POTS and autonomic dysfunctions. We have an exercise physiologist, Adrian Elliott, who's focused on the interplay between arrhythmia and exercise. And we will hear from Jeroen Hendricks on really implementation science in the field of arrhythmias. We also have a bunch of emerging leaders in this area. Celine Gallagher, who helps out with Jeroen's group, Chris Wong, who's focusing on big data management, Melissa Middledorp, who's working on the epidemiology side, and then Thomas Agabang, who is working on the preclinical studies and runs our preclinical laboratories. I also want to highlight that we closely work with Tanya Hall, who's a patient advocacy organization. Tanya's shaped a lot of our studies, having the input from the end user in several of our studies and forms part of our group. So while we're talking about atrial fibrillation, and this is work from Celine Gallagher, really looking at cardiovascular hospitalizations over a 20-year period here in Australia, and shown in blue is the increasing numbers of patients with atrial fibrillation, such that now this is a more common cause of admission to hospital in Australia than either myocardial infarction or cardiac failure. And therefore you can imagine the kind of burden that has on our healthcare system, and hence the interest in looking at how we may be able to prevent this. While we've known cardiac disease causes atrial fibrillation, what is emerging is that there are several modifiable factors that influence this also. And these are things that we potentially have an avenue to treat in order to achieve success. Obesity and physical inactivity, hypertension, sleep apnea, diabetes, dyslipidemia, alcohol, and smoking. And our group has worked on a number of identifying factors in terms of determining how these conditions lead to atrial fibrillation. And this has been an important aspect of some of the research that's been done within our center. I want to just highlight a couple of these. This is a paper that was published only in the last month or so. This is from Samuel Tu, who's one of our medical students working with Chris Wong, looking at the UK Biobank data in terms of alcohol use and incident atrial fibrillation. And what's very neat here is that they actually show that up to 6 standard drinks for a week may in fact be protective against atrial fibrillation. But after that, we start to see an increase. But not all alcohol is equal in this series, where wine may be better than beer or spirits in terms of the risk of developing atrial fibrillation in the de novo situation. And we've got this kind of data for each of these risk factors that we have. But what we also know is that these risk factors result in damage to the atrial tissue. And I want to show you these studies. This is from Hani Abed and Rajiv Mahajan when they were undertaking their PhDs with us. So they took this to our preclinical laboratory. They looked at feeding sheep such that they became overweight and obese. And what we were able to see was, as shown here, is in red, is fibrous tissue forming within the atrial myocardium. So there's increase in fibrous tissue. Here's what happens to the fat cells in the epicardium. On the left is showing the well-demarcated baseline situation. And on the right is where there's infiltration of fat cells into the myocardium, which forms part of this substrate. In this way, this alters the electrical properties of the heart muscle, giving rise to greater atrial fibrillation. And we've seen this with each of the risk factors that we know that are modifiable. So what we've taken up as a challenge is to see if we can actually reverse some of this by treating these risk factors. And we've done this in a comprehensive risk factor management clinic. And I put here the various targets that we've used for various risk factors, and these are now being extensively published and accumulated into guidelines in terms of how we may manage a patient with atrial fibrillation to look at whether we can treat the AF itself. And I want to show you some of the data which has pushed this information into guidelines. This is the first of our studies. This was a randomized control study done by Hani Abed as part of his PhD. He looked at aggressively taking people off our AF ablation waiting list and treating them comprehensively for risk factors. And you appreciate that over a 15-month period, he got the weight down 5.6 points in BMI, which is significant. And on the right is shown a validated symptom score where patients who underwent risk factor management had significantly fewer symptoms. Their AF frequency, burden, severity, and also their symptoms all reduced, and they're reported being well. Many of these patients did not need to progress to AF ablation as a result of such an intervention. We've now gone on to create a prospective registry that now has over 600 patients that have been collected in here with AF. And we've presented each of these studies in various late-breaking trial sessions around the world. Arrest AF looked at what happened in terms of AF ablation outcomes, and we found much better outcomes if people retreated their risk factors. Legacy looked at quantifying the risk factor management by the degree of weight loss. This is as a measure of overall risk factor management. The greater degree of risk factor management, the more likely someone was to maintain sinus rhythm. In CardioFit, we were able to show that the addition of aerobic fitness further improved the ability to maintain sinus rhythm. I'm going to go into detail further with reverse AF. Now, the natural history of atrial fibrillation is that one progresses from paroxysmal to persistent and then permanent atrial fibrillation. Here's what happens when we manage risk factors, and this is color-coded, where green is where risk factors are not managed and there's less than 3% weight loss, through to orange, which is showing greater than 10% weight loss. So progression from paroxysmal to persistent AF occurs in almost half the patients over a 5-year period if their risk factors are not managed well. Only 3% of people where their risk factors are well managed. But here's an incredible thing that we found, was that if you went from persistent to paroxysmal AF or no atrial fibrillation, almost 90% of people who manage their risk factors reverse the type of atrial fibrillation, and really gives hope to us in terms of being able to reverse the underlying disease in these patients. So this is something that's just been published from Rajiv Mahajan, which he did as part of his PhD. We took this to our preclinical laboratory, and here we took chronically overweight animals. We diet restricted them and got them to lose weight. And I'm only going to show you one section of this. On the left of this panel shows a lean control. And then we have the obese animal atria. The blue shows fibrous tissue. There's an incredible amount of fibrous tissue that forms within the atria. When this animal loses weight, 15% and then 30% weight loss to the right of the screen, we see that this fibrous tissue disappears. And in fact, a number of these factors reverse, and these animals have less atrial fibrillation, and it kind of marries in with what we've seen clinically and gives us hope that we may be able to reverse the disease process. So with that, I want to bring you to this. The title of my talk is that we've managed to introduce a fourth pillar into the management of atrial fibrillation. It's no longer just anticoagulation, rate, or rhythm control. It's risk factor management. I've boldly put this as the first factor that we should be managing, mainly because it affects every other management step in these patients. I want to highlight introduce Jeroen's talk by highlighting that education and integration of this management is crucial. And there are several factors here. The patient needs to take ownership over the issues. There needs to be a team, and we need to be able to successfully deliver all four of these pillars in the management of atrial fibrillation. So I'm going to hand over to Jeroen, but before I do, I'd really like to acknowledge all of the clinical and research fellows that have been through over the last decade in our service who've contributed to this work. Thank you.
Thanks, Prash. Jeroen, as previously stated, is an integral part of the EP team, is the inaugural Leo Maher Cardiovascular Nursing Chair at the College of Nursing and Health Sciences at the Flinders University in the Department of Cardiology at the Royal Adelaide Hospital. So delighted to hear his insights into the integrated care model.
Thank you very much, Matt, for the kind introduction. So it's my pleasure to talk about integrated care for patients with atrial fibrillation. And by doing that, I would like to start off a few years back. So this is the first study looking into redesigning AF care and looking into the use of the AF clinic. So this was a trial done as part of my PhD in the Netherlands, where we really focused on a simple intervention where a nurse collaborated with a cardiologist, provided the treatment according to the guidelines, and used a dedicated software system. We then performed a randomized controlled trial and recruited newly diagnosed atrial fibrillation patients and randomized them into the integrated nurse-led approach versus usual care delivered by a cardiologist. And at final follow-up, we looked at the primary endpoint, and we can see that here in the Kaplan-Meier curve. So this is a cumulative incidence of the composite of cardiovascular hospitalization or mortality. And at final follow-up, we saw a significant 35% relative risk reduction in favor of this nurse-led care approach. Now then we asked ourselves the question, are current models still suitable to provide required care for patients with atrial fibrillation, or do we need to explore novel models of care? And as Prash already mentioned, there's an increasing prevalence and burden of atrial fibrillation, but also the treatment of atrial fibrillation can be quite complex. At the same time, integrated care has been identified as a suitable approach to manage patients with chronic conditions such as atrial fibrillation. And what that actually means is a worldwide redesigning of care and implementing novel models of care to improve outcomes, but also to prevent fragmentation of care. Now, the World Health Organization has provided a definition on that, which sounds as a concept of bringing together inputs, delivery, management, and organization of services across the continuum of care. And if we look into the figure, we can see that here, there's a patient with a chronic condition in the center approach, and the care is organized around the patient with elements such as coordinated services, team-based care approach, and the use of technology is more and more important. Now, the European Society of Cardiology updated their guidelines for the management of atrial fibrillation last year, and they provided this figure on integrated AF management. And if we look closely into that, we can identify four main fundamentals of integrated care. First of all, we have a patient-centered approach, what means that we need to actively involve our patients in their care, but that we need to educate them and prepare them to self-manage their condition and focus on their lifestyle modification. It's no longer that there's one healthcare professional providing the care, but it's now a multidisciplinary team where a cardiologist, a nurse, and allied professionals, amongst other specialists, work together to provide the appropriate care. And as Prash just mentioned, the four pillars of atrial fibrillation, it is nicely aligned here with the treatment of atrial fibrillation, optimized stroke prevention, but also the management of cardiovascular risk factors and underlying conditions. And then there's the fourth pillar, the use of technology to promote medication adherence, but also to really promote a structured follow-up. To identify how important education is in patients, we performed the HELP AF study, the home-based education and learning program in patients with atrial fibrillation. And in this randomized control trial, we recruited patients with a diagnosis of atrial fibrillation who presented to the emergency department. And afterwards, they received 2 home visits by a nurse or a pharmacist. And they provided key messages in education. So they looked into the importance of taking their medication, that stroke prevention is really important in reducing strokes. They introduced the concept of a healthy lifestyle, and they also provided a personal action plan for patients to use if they had a new episode of atrial fibrillation. And what we found in 627 patients, we found that there's a reduction in unplanned hospitalization. So with 26% reduction of total unplanned hospitalization, 31% of AF-related hospitalizations, and almost 50% of other cardiac hospitalizations. And the key message was here that a personalized education approach is essential for individuals with atrial fibrillation. And that's why we incorporated this also in the iCare AF approach, integrated care for patients with atrial fibrillation. And we can see here these 4 fundamentals again. So a patient in the center of the treatment, a patient-centered approach, with around the patient those specialists that may be involved in the treatment for patients with AF, but that is depending on the individual situation of the patient. But directly around the patient, there's a core team consisting of a cardiologist, an AF nurse, the family and the care of the patients collaborating with the patient, and this is guided by technology as well. So this rapid access clinic integrates atrial fibrillation specific and risk factor management. And we believe that all patients with atrial fibrillation with a new diagnosis of AF should have at least 1 visit in such a specialized approach to do a full diagnostic assessment and also initiate treatment according to evidence-based guidelines recommendations. Again, it's really important to have the patient involved. So engagement, education, and empowerment to undertake self-management are really crucial in here. But it's also important to realize that we really need to redesign practice to implement such integrated care approaches. We also developed a patient app to keep patients involved, where we provide them with further education, but we also want them to work with the app. So we ask them to maintain a food and lifestyle diary, and we ask them to report their symptoms if they have any episodes of atrial fibrillation and measure, for example, their weight and their blood pressure. So this approach is now implemented at the Royal Adelaide Hospital in outpatient services and at the Cardiovascular Centre in Norwood. And we're alongside this clinic, we're running a randomized controlled trial in which we try to recruit 1,376 patients with a confirmed diagnosis of atrial fibrillation who have presented to the emergency department or who have been admitted to hospital or referred to outpatient AF care. So the primary endpoint will be a composite of all-cause hospitalization and mortality. And we have a number of secondary endpoints as well, really looking into patient-reported outcome measures, but also looking into the effect on healthcare utilization and cost effectiveness. And we will follow these patients for 2 years, and the patients will have, in the intervention group, will have determined visits to visit the nurse in the outpatient clinic, where we will work with them on their risk factors and provide them with further education and empower them to undertake their lifestyle modification. Now, future plans and implications based on this approach, I think what we want to do is to implement this iCareY approach in other medical centers across South Australia, but also interstate. We would like to expand the approach, especially the core team with links to general practice. So really to have a good collaboration with general practices. It is possible to translate this approach into other chronic cardiovascular conditions. And I think it's important to identify research priorities within integrated care for atrial fibrillation. And Prash and I have just been involved in a collaboration with the National Heart and Lung and Blood Institute in the US, and really looked into the importance of integrated team-based care. We identified important knowledge gaps and also research priorities. So I think this is really interesting for the near future. So just to conclude, integrated care is an emerging approach where we provide comprehensive care for patients with atrial fibrillation. It consists of 4 main fundamentals that should be present in such an approach. Every fundamental is important, but the fusion of the 4 elements is really makes it the integrated care approach. I think implementation of integrated AF services is really important. It should be done structured, but also requires a redesign of the current healthcare setting. And already research has demonstrated the potential value of integrated care for AF, but the current trial is really to demonstrate its efficacy in the Australian setting, because we don't have any data for Australia yet. I would like to acknowledge the implementation and support team that I'm working with, and I'm very thankful to have these people on board, and also acknowledge the clinical and research fellows that I've been working with and still working with. Thank you very much for your attention.
Jeroen, that was absolutely fantastic. Thank you so much for that, and for both of our presenters for excellent presentation. We will wait. Please feel free to add to the chat or the question and answers. We have a few minutes left. Prash, my first question to you, I'm fascinated by all the data that you presented. The weight loss data in the sheep I find amazing. As a simple cardiologist, the whole concept of fibrous tissue for me has a bit of permanency to it, yet you found that the fibrotic aspect within the atria reduced when weight loss occurred in your sheep. Chronic, for want of a better term, chronicity in obesity, so long-standing issues with obesity, do you know whether that renders that fibrotic tissue more recalcitrant to remodel, to disappear, for want of a better phrase?
I think that's an interesting statement, Matt. So I think we're used to thinking of fibrosis in cardiology as myocardial infarction, that is replacement fibrosis, whereas actually most fibrosis is actually reactive fibrosis, which is what we're seeing in this kind of stress-induced, and it's interstitial as opposed to cellular death fibrosis. Interestingly, I presented 2 sheep studies. The sheep used in the second study were the leftovers that weren't needed. And so that actually gone, there were 3 years between the 2 fellows. They actually could reverse after 3 years of chronic obesity in that sheep model. Wow. Now, it's quite possible that if you took a clinical situation where you have long-lasting persistent AF with morbid obesity, and they're seeing a lot of this in the United States, that there may be a situation which is not reversible, but we're yet to kind of determine that at this point.
The last question is a lot of the risk factors that you've presented, Prash, are often closely linked: obesity, alcohol, hypertension, obstructive sleep apnea. Is it important to tease out which one of those is most important, or is it not important to tease out if obesity will impact on obstructive sleep apnea and hypertension, let's say? Is that difficult to process? Yeah.
Look, I think AF is multifactorial causes. And so treating one factor in isolation is really going to be beneficial. And in fact, most studies that have done that have resulted in a negative result. Now, where that may be different, and there's an elegant paper from Melbourne in the New England, which looked at alcohol in people who are drinking significant amount of alcohol, and looked at abstinence, showing that AF goes away. Now that was dramatic. They couldn't sustain it more than 6 months because no one wanted to give up the alcohol. And similarly, we've seen in severe hypertension where renal denervation is used as an intervention. People on 5 drugs, treating just hypertension has been useful. But in the vast majority of the patients that we see clinically, it's multiple factors. They're at modest levels, and unless you treat each of them, you're not going to see the success in terms of reducing AF burden.
Thanks, Prash. Still, while we've got 1 or 2 minutes, Jeroen, that was a fantastic tour de force. This has been, so an integrated model of care for heart failure has also been shown to be of benefit. I'll throw you a question. Is there a chronic illness where you could guess perhaps your program wouldn't show benefit? I think it might be aligned in so many different chronic illnesses to be of benefit if proven.
That's right. I mean, there has been already research done, for example, in diabetes, in COPD, like even in end-of-life care. I think it's really important to translate it and to have, for example, if you look at a multidisciplinary team, to have the right people on board at the right time for the right patients, having the patient involved, looking at what is really important for the patient, and how can we align that with what is recommended by the guidelines, for example. These kind of steps are really important, but I think there's much more possible within integrated care, and I think it's translatable to any chronic condition. So I think there's much more to come in the near future.
Yeah, the cost effectiveness must also be there as well, I suppose, as a head of unit and perhaps being empowered to count the pennies more than I have in the past. Your last slide, to conclude, had lots of different healthcare professionals. Is there a precision medicine approach of tailoring what particular healthcare professionals you need for certain patients? Is that sort of part of your, so I assume not one shoe fits all?
No, exactly. No, it comes down to tailoring and really like looking at the individual case of the patient and determine what kind of patient, what kind of specialists need to be involved. Sometimes it's even not necessary, and you can do that with the core team. So it's really, yeah, precision medicine is an important aspect. And to get back to your question on cost effectiveness, in the study in the Netherlands, we looked into that and we reduced the number of hospitalization, which is the main cost driver of AF management. So for the public sector, that would be a very interesting approach. And well, I hope we will be able to show that with the CAREY study as well.
Look, I just would like to thank you both for your time and really informative presentations today. So I thank you all. Just to remind you that next Tuesday's presentation is on industry with Mr. Kurt Sales, Mr. Mark Rowe, presenting with Ms. Yvette van Ineman. So I thank you all for your time, and I wish you a good day. Thank you.